We've tried to follow the integrated patient-centric model and provide all facets of cancer care for our patients under one roof. We have one primary site here in Lincoln. We round on patients at 3 hospitals here in our community. We also have outreach clinics in 11 surrounding communities. Practicing in the community setting can be a wonderful experience in that our relationships, I think, are very close with our patients.
Patients see us in the community, at sporting events, at various support groups in town, the fundraisers, the cancer walks. I think patients really value knowing that their physicians that are taking care of their cancer are part of this community.
I view community oncology as being on the front lines of taking care of cancer patients.
The data shows that we, in community oncology, we're able to provide the highest access of care to patients, the highest quality of care to patients in the most cost-effective manner. So the biggest challenge right now is to sustain what we do well, despite some of the policy changes that are trying to come our way and have come our way.
Without community oncology, I think access to expert care would suffer. Continuity of care for the patients would also suffer. I think we would move away from more of a one-stop shop setup to more fragmented care. Without question, cost of care would also rise, not only for the patient, but for the taxpayer.
For a long time, we've had the luxury of just rolling up our sleeves and taking care of patients. And now it's become clear that changes are happening. There's clearly a need to reform the way healthcare is delivered in America. Those changes are happening.
I think physicians are having to take a hard look at the business model of their clinics and try to become much more efficient.
We made a decision to look at what we do well and see if we can do that better. Things like drug inventory management. We have a pharmacy. We made the pharmacy bigger. We have state-of-the-art imaging. We could have made a decision to maybe cut costs there, but we doubled down on that and offer more services. So far, that's worked for us. We've been able to sustain this 30% cut that was forced upon us. It's not a long-term solution. Right now, 30% of the drugs that we use for the 3 most common cancers, breast cancer, colon cancer, lung cancer, are underwater. We pay more for the drugs than we are getting reimbursed. That's not a sustainable model.
If we continue on the path that we're on, ultimately patient care is going to suffer. Our job as medical oncologists is to band together, stand up for our patients, and communicate to our policymakers so they understand.
At heart, I'm an optimist. I think you have to be somewhat to go into this field. We know the value of community oncology, what we bring. We have to get the message across to people that are making the policy so we can continue to do what we do well.